in patient care in an individualized therapy. Sorry.
Okay, sorry, there's an error with with our presenter. Give me a minute. All right, Brother Shahid already inside, already joined. Can you present back your slides?
Sorry for just now. Kat mana saya boleh tengok kat sini
Baru slide pertama tadi.
Yang ni
Yes, betul.
Okay, so basically what we do in therapeutic monitoring, we focus on pharmacokinetics and pharmacodynamics model in predicting the treatment response. Okay, pharmacokinetics depend on a variety of physiological variables and pathological condition. The influence of physiological and disease changes on pharmacokinetic parameters may help in predicting and optimization of drug response while minimizing its toxicity. Careful dose adjustment with routine monitoring of adverse event is necessary in the population with altered PK. Altered PK that involve administration, distribution, metabolism, and elimination, like I said just now. So three main specific population that we need to focus on is critically ill patient, pediatric patient, and geriatric patient. Okay, therapeutic index drugs involved which that we can do the TDM monitoring in our hospital is first group is antibiotic, which is aminoglycoside and vancomycin. Okay. First, we need to focus on time to achieve steady state. What is steady state? Steady state is when the amount of drugs absorbed and amount of drug eliminated is equal. It is also mentioned that when steady state, the concentration of drugs in body remain constant. Okay, so it is important to know when the drugs will achieve the steady state, because we want to avoid taking sample before the steady state, because it may lead to invalid result recommendation or interpretation. Okay. For aminoglycoside, for normal renal function, usually from third to fifth dose, it will achieve steady state. For impaired renal function after 24 hours. Okay, for sampling time, there is many recommended sampling time, but usually in our normal practice, we usually take pre-third dose. Okay, it also depends on the patient and on the dose regime, such as single daily dose, SITI, or conventional multiple daily dose or synergistic dose. Okay, for dialysis patient, initially we will take sample from 18 to 24 hours or subsequent pre-HD, before HD lah, usually within 30 minutes before the HD patient, HD started. Okay, for therapeutic range, also depends on the regime and on the the condition of the patient itself. Okay. All right. As you can see, at the gentamicin side, we also have the therapeutic range for the synergy indication, because this medication usually we use synergistically in patient which have the infective endocarditis. So for this patient, we also need to do the TDM also. Okay. For vancomycin, normal renal function also, we usually will achieve steady state from third to fifth dose, and impaired renal function also after 24 hours. For sampling time, usually we will take the sample, recommended to take the sample before 30 minutes before fourth dose. For dialysis patient, usually in 24 hours after first dose, and subsequently 48 hours after dose, or also with recommendation from pharmacists. Okay, for continuous infusion, I will talk later, because our hospital have endorsed our own protocol for vancomycin infusion, continuous infusion for ICU. Okay, for therapeutic range for vancomycin, usually we take from 15 to 20 mcg per ml for complicated infection. Okay, for sample tube, it is important to know which sample tube to take the sample, because there is a few times we receive vancomycin sample in ECTA tube. This we cannot, if the sample is taken in the ECTA tube, it will affect the blood, and the analysis cannot be done. Okay, this is taken from the vancomycin continuous infusion protocol for ICU. Okay, for a dose, loading dose, usually we will start from 15 to 20 mg per kg, with the maximum dose of 2 gram for normal weight and 3 gram for obese. For maintenance dose, after finishing giving the loading dose, we will straight away start the maintenance dose with 30 to 40 mg per kg per day. Maintenance dose will be adjusted based on TDM level. For administration, infuse each 1 gram over 1 hour, because there's quite common for Redman syndrome to occur that related with the infusion rate. Okay, for initial rate before first TDM, for normal renal function, usually we will use as 50 mg per hour, and we will adjust it according to the TDM level afterward. For AKI or CKD patient, we will use 25 mg per hour. Okay, for therapeutic drug monitoring, the sampling time is after 12 to 24 hours, and every 24 hours after first TDM, or depends on pharmacist recommendation. Right. Next group is anti-epileptic. Carbamazepine time to achieve steady state with the initiation dose is 2 to 3 weeks. Then after dose adjustment, if we start this with initiation dose, then we do the TDM. After which we need the dose adjustment. It will take 2 to 5 days more to achieve the steady state for the new dose. Okay. For sampling time, usually we take pre-label, which is 0 to 30 minutes before next dose, with the therapeutic range of 4 to 12 mcg per ml. For phenobarbital, if we give the patient the loading dose, it is 2 to 3 hours after initiation of loading dose. Without the loading dose, it will take a longer time lah, which is 2 to 4 weeks. Okay, for sampling time with loading dose, 2 to 3 hours of initiation, we can straight away take the sample. With maintenance dose, we take 0 to 30 minutes before the next dose, next maintenance dose. The therapeutic range is 15 to 40 mcg per ml. Okay, for phenytoin, also the same with the phenobarbital. If patient have been given a loading dose, after 2 hours for IV and after 24 hours for oral, which is a steady state. Without loading dose, it will take longer, which is 7 to 10 days after initiation or change of regime. Okay, for sampling time, after 2 hours of loading for IV and after 24 hours for oral. All right. For maintenance dose, it is a pre-dose, which is 30 minutes before next dose. And the target normally is 10 to 30. Sorry? Yeah. Okay, I will proceed. So for valproic acid, time to achieve steady state is 2 to 4 days after starting the dose. And the sampling time, it is recommended to take pre-dose also 0 to 30 minutes before the next dose. And the therapeutic range, based on the indication itself, for epilepsy, usually we target 50 to 100 mcg per ml. And for psychiatric disorder, we target a bit higher, which is 50 to 125 mcg per ml. For sample tube, also we use the plain tube, which is a yellow cap tube. Okay. For the next group is theophylline or aminophylline. Time to achieve steady state differ on the age of the patient. For adults, 2 days, children, infant, newborn, and premature neonates. So we have to classify them according to their age. Okay. Sampling time also we take the pre-dose, and therapeutic range also differ based on the indication. The apnea, ventilator in units, or asthma or COPD. Okay, for digoxin, with loading dose, it will achieve steady state from 12 to 34 hours. Without loading dose, 5 to 7 days after change of regime. Okay, for ASRD patient, it will take longer, which is 15 to 20 days. Okay, for sampling time, it is recommended to take before the next dose. And if the patient have already taken the drugs, for oral at least 6 hours after the dose. For IV, at least 4 hours after the dose. Okay, the therapeutic range also differ based on indication. Okay, for salicylate, for therapeutics, it will achieve steady state in 5 to 7 days after initiation, and for toxicity, 4 hours after ingestion. Okay. It is important to know the exact time of ingestion for salicylate and paracetamol. Okay. Therapeutic, for therapeutic, sampling time is 1 to 3 hours after the dose. For toxicity, 4 hours after ingestion, and repeated after 2 hours until it falls. Okay. For therapeutic range also, there is 3 main focus on therapeutic and differ accordingly. Okay, for paracetamol, toxicity, usually we do the TDM if there is suspected toxicity. And the steady state usually achieved within 4 hours after injection. Okay, if we unknown injection time, we have to take 2 sample at 2 hours interval. Okay, for therapeutic range, usually we refer to room magnitude nomogram. Okay, for MTX, time to achieve steady state is not applicable because this is anti-metabolite that alter the metabolism of folinate. Okay, usually the sampling time we take the sample post 48 hours and post 2 hours. Our target is to achieve the level below 0.1 micromole per liter. Okay, if the level do not fall until the target range, we will continue to monitor every 12 hours afterward. And during waiting the level to fall, we will give a folic acid rescue. Okay, for cyclosporine, then to achieve steady state, it usually 3 to 5 days. And sampling time 30 minutes before next dose. And therapeutic range based on diagnosis. Usually, if I'm not mistaken, 100 to 500 mcg per mil. Our main target level lah. Okay, for sample tube, for cyclosporine, we need to use the ECTA tube. If you use the plain tube, it will affect our blood sample. Alright, this is a methotrexate TDM guide that our hospital have endorsed last year. So based on sampling time and MTF plasma concentration, we will continue the folic acid according to the level lah. Okay. Okay, these 3 group of medication is narrow therapeutic index drugs that can be done, but we have to do it outsourced because we don't have the specific reagent to analyze the sample lah. Okay, last month we got 1 sample of tacrolimus, but until today we still didn't get the result because usually outsourced sample it will take longer time to get the result. Okay. Okay. Reminder, must use correct tube because there is like I said just now, there is a few times sample comes with wrong tube, so it will the analysis cannot be done. Okay. Each sample must be taken adequately. 5 ml for adults and 600 microliter for neonates. If you want to request more than 1 sample analysis, need to take more sample according to test. Usually this happens for patient with anti-epileptic drug. If usually patient on currently on Epilim or Keppra, we can do the test simultaneously, but you need to take more sample lah. Incorrect sample given will lead to sample rejection. Okay, therapeutic drug monitoring form. Okay, this is example of therapeutic drug monitoring form. If you have see the hard copy of this form, usually it purple in color, and this form is not the latest version because in latest version we already add methotrexate and if I take the second cyclosporine, cyclosporine in the drug analysis table. Okay. Okay. For patient demographic data, you must the important part is you have to fill weight and height of the patient. Okay. And requested sign of action. Then patient condition, you have to take if the patient has edema, dehydration, smoker, dialysis, burn and liver disease. kindly be reminded that this is also important in the interpretation of data. Indication of request. If you want to do the routine therapeutic monitoring, just stay at therapeutic monitoring. And if patient is suspected toxicity, kindly take the appropriate table square. Okay. For concurrent medication, you have to, if a patient on so many drugs, you can only put medication that you think have major interaction with the current drug, especially for suspected toxicity that you think other medication also might involve in that may lead to this suspected toxicity. Okay. For the last table, which is drug analysis, this is very important because there's a quite few form that we receive where they only take the medication and fill only current dosage, date and time started, last dose given, type of sample, and sampling date and time left unfilled. So because during interpretation, especially for antibiotics, usually we will do the calculation, and the sampling time is very important to do the calculation lah. Okay, so I want to ask everybody to make sure before send the request form to lab, you must make sure all the details have been filled. Okay, as you can see, the right side is the back of the form. Here we already provide serum sampling guide. Okay, so from here you can refer, and if anything you want to confirm, you can call me back later lah. Okay, reminder: make sure all the information regarding sample time are filled correctly. Incomplete data may slow down the result correction and the interpretation by pharmacists. Okay, for TDM reporting, the measured level will be reviewed, calculated, and interpreted by pharmacists. Then pharmacy will communicate verbally with the prescriber requester first before update in the IPO sakit. Okay, so in the IPO sakit, after I have called you guys to inform the result, usually I will update result in the IPO sakit. There is two way to view the result. First is at the summary, patient notes, therapeutic monitoring notes. Then at the lab result module. Okay. Okay, for urgent toxicity cases, any suspected toxicity cases that caused by neurotherapeutic index. Okay, then any urgent cases that involve critically ill patient. Okay. Any toxicity agent cases which happens after office hour, prescribers need to call and inform pharmacists on call before send the blood sample to the lab. This is because we are not actively present at the hospital after office hour. So it is important for you to call, and we can do the preparation if we have to come to the hospital lah to analyze the data. Okay, I forgot to mention our TDM services integrated with lab. So the sample will be sent to the laboratory to be analyzed by lab staff. So during after office hour, there is also no science officer to run the sample. So if you call us and inform us prior, we can prepare from IFO side and our laboratory side. Okay, how to reach us? Okay, for normal working hours, which is 8 to 5 p.m. on weekdays, you can contact me at my extension 2551, and our second person, Sila, or CPS unit with the extension of 1610. Okay, outside working hours, from 5 p.m. Until 7:59 a.m. On weekdays, we have pharmacists on call. Okay, from on the weekend, from 10 a.m. to 6 p.m. we one pharmacist will be active at the inpatient pharmacies, and if anything, if we have toxicity, you can directly call inpatient pharmacy, or you can also direct call to pharmacist on call phone. Okay, I think that's all from my side. Is there any question that you want to ask?
Thank you to Brother Shahid. Any question from the audience? All right, there's no question in the chat box as well. Let's see. Question from the audience.
Rasa tak ada dapat.
Okay, if there's no question from the audience, then don't forget to fill out the feedback form and to get the CT points. And thank you to Brother Shahid for the sharing session today. And without further ado, we postpone our seminar today with the Istiqara and Surah class.
Okay, thank you. Assalamualaikum.
Waalaikumsalam.